and to the cloud. Okay, so let's have a look. Salah, you can start on this one. This is a gentleman. Here we go. So first of all, can you see that image?
Yes.
Good. So this is a gentleman. He had an angioplasty that was performed uh, a few days ago. I haven't written down exactly how many days ago.
Yeah.
And he's come in with a groin lump, and you've been asked to evaluate it. Okay. So if I can just get you to describe what you're seeing, tell me what you think the differential is and what further you might look for with ultrasound.
Any more images or only these two?
Start off on that one.
So there's a right groin ultrasound in both long and sagittal plane with the measurement of 15 by 15 by 16 millimeters. Um, like it's a bit hard without having color
Yeah.
to evaluate whether this is a vascular structure or not.
Yep.
The first
Mhm.
thing I can see there is the measurements taking almost to the lumen, but there is a little bit of increased echogenicity around it, which is almost like
Yeah.
a whether there is a mural thrombus within the
Yeah.
vessel.
Yeah. That's all right. So, I mean, I agree with you at this point. You can see there's a lump there. It's pretty hard
Yep.
to know more about it. So, that leads into the next question, which would be, what else would you do? You've just put the probe on. This is what you've seen. What are you
Yep.
going to do next?
So the next thing I will do is put color
Yep.
to look for vascularity, whether this
Mm.
hypo echoic lesion is vascular or non-vascular.
Yep.
Um,
Okay, so let's do that. So there's actually two things that have been done in that image. One is color's been put on.
and there's depth increased as
Yeah.
well.
Yep. All right.
So
So having seen that, how would you describe that?
I will say this is likely present it's vascular structure and there is color flow within
Yep.
and it's giving it the right groin, it's probably the right femoral artery, I would say. Um, there is a bit hard, Adrian, whether there is like a almost on the I don't know, to be honest. Like, I don't want to say something that is
Okay, so so it's a vascular structure,
yeah.
as you pointed out. I mean, you can see down here you've got this thing pulsating, this thing doesn't pulsate. So that's the femoral artery and the femoral vein, you know. And I told you he's had an he had an angioplasty or an angiogram a few days ago.
So like, clinically, I would think of like, from history wise whether this is a pseudo aneurysm
Yep.
following the procedure.
Okay, so what are the features of a pseudoaneurysm?
Uh, Not sure.
Okay, all right. Ben, you're sort of next down on my screen. Do you want to jump in and help with a couple of things?
Um, I can't remember exactly, to be honest, but I
All right.
guess it would be a defect in the wall of the vessel,
Hmm.
leading to a pulsatile mass around it.
Yeah, so I mean that's the definition is that there's a defect in the wall and that the difference between a true aneurysm and a pseudoaneurysm is whether or not it has a proper wall, and in a pseudoaneurysm it doesn't. Okay, a wall and an endothelial lining. Okay. Has anyone heard of the yin yang sign?
No, but
No.
I'm guessing that's what it looks like.
All right. That's not a bad example. It's supposed to be a little more of a swirl on the top, because you'll see if you think about what happens with the blood as it comes in, it's going to come in one side, and I'm assuming, can you see my arrow?
Yes.
Yeah. So, the blood will come in and it'll come up and then it'll swirl round. So you get the different colors, and that's called a yin yang
It's like a Pepsi Cola.
sort of on there. Yeah. So yes, if you are more of a follower of American culture than Eastern mysticism, you can go for Pepsi. Okay. So that's one thing. All right. I mean, you can actually see on there, that looks like where the blood's coming from.
Yes.
All right. So one of the descriptors of a pseudoaneurysm is that with color Doppler, you get a yin yang sign. You can also often see the path, okay? And this is called the neck, obviously. All right. Sorry, we'll just go through that. All right. Has anybody, I guess, as I said, you haven't had the lecture on this yet, but is anybody want to comment on what that spectral Doppler is showing?
Showing biphasic flow,
Yep.
predominantly towards the Doppler angle.
Yeah, it's one thing you've got to be a little careful on this. This
Oh, it's
machine
inverted.
says for some reason this machine, when it was trying to automate measurements, it would decide which way up it should be and would often flip it. So it is a little confusing,
Okay,
unfortunately. So this is actually the flow towards the probe, and this is the flow away from the probe.
that makes more sense, I guess. So
Yeah,
pulsing in and then
yeah,
slowly emptying out.
yeah. So again, that is an absolutely classical flow pattern that you see at the neck, in the neck of a pseudoaneurysm. And that's one of the things you need to look for in order to say that this is a pseudoaneurysm. Because as you say, with the arterial pulse, the blood squirts in, and then, it's like a balloon going, and then coming down. And then you have the slow flow as it comes back out. Okay. All right. So both of those things are, as I said, standard descriptors when you're talking about pseudoaneurysms. There are a couple of things that we always like to describe when we're talking pseudoaneurysms. Anybody got any comments? What things do you think might be important in terms of management?
Size,
Yes.
the I suppose if if it's previously known any change in size and how rapidly that's changing, probably the
Yeah.
size of the defect as well,
Yeah.
and what
So,
it's coming off.
yeah. So we talk about the size of the pseudoaneurysm, but often what's actually more important is the size of this bit, the neck. So you need to know the size of the neck, and also, I mean, this pseudoaneurysm, you could see from that, if we go back to the original, uh, that's quite a long way away. So the treatment for this used to be thrombin, well, still is thrombin injections. We see these less commonly than we used to, because they now put fems,
Stop. The
yeah,
famous stop.
the stops in to reduce them.
Stop.
Is FemStop the name of the device, or is FemStop the thing that you used to put on to compress them? Can't remember.
The
Anyway,
famous.
they put the little occlusive things in to try and reduce it. Certainly, and also they do a lot more through the radial arteries now. So they're much less common than they used to be. But you can imagine if something had a really broad neck or a short neck, that makes it more difficult, because the standard treatment for these was that you used to put a little bit of thrombin in. But of course, if you put too much thrombin in, then it's not only going to thrombose the pseudoaneurysm, it runs the risk of thrombosing the artery and giving you an ischemic limb. So the ones that had a narrow neck and a long neck were very suitable, but one that has a short neck and a wide neck is much more problematic in terms of using thrombin, and in terms of, this, if you needed to surgically tie this off, you've got a lot of space to do it. Whereas, of course, if it came straight off the artery, much more difficult. And so they'll stent a lot for those sorts of pseudoaneurysms. They'll often stent them, these sorts of things. So there's a number of treatment modalities. So it is important to look at and to think about and to describe the neck, both in terms of the length and the width. Pseudoaneurysms, absolutely need to know those quite comprehensively, be able to describe the signs that you're seeing. The one other word, of course, on grayscale is you say pulsatile. So on grayscale, it's pulsatile. On colour, there's colour filling, there's a yin-yang sign, and on spectral Doppler, there's the to and fro flow at the neck or in the neck. Okay. All right. Let me stop that for a moment. Okay. So why don't we go on to this one and we'll start talking about stents. So it's probably not really a question for the cases as to why we don't use ultrasound very much. That's something you're more likely to get in the written, but it is something you need to know. Because as I said, certainly I get asked not uncommonly, oh, this person had a stent, they got some back pain. Can you tell me if they got a stent leak? And the answer is, if it's really big, but there are actually some ultrasound features that will say, yes, there is a stent leak, and you need to be able to either rattle them off or more likely type them down very quickly, because it's a not uncommon exam question. Okay. So let's just share my screen again and we'll go through and have a look at this. Okay. Who did we get down to? Andy, I think you're next on my list there. So not surprising. That just shows there is a stent. We'll move on from that. Sorry, I wish this would repeat. So what are the sorts of things that you might be thinking about looking for, given what I've said, that we're going to be looking at a stent? This was somebody who, that's right, previously known stent leak. They had an attempted repair with glue to embolize the leak. Okay, so again, you may not have covered this. Do you know where stent leaks occur and what the classification of them is?
Yeah, so there's types 1 to 4 and plus sometimes a 5 categorization of endo leak. I'd struggle to remember exactly, but some of them come from external feeding vessels.
Yep.
I think that's type 2 or 3. Type 1 is where you get a gap between the stent and the lumen of the aneurysm and get a leak that way. And then the other two types, I can't remember the order. One of them is you get leaking through a defect in the graft. And then one of them is where you actually get blood coming through the fenestrations in the stent, but I think that usually resolves at the time when the stent's put in.
Yeah.
And I haven't learned which types are which, but yes.
Yes. So there are 5 types, and I also usually need to look up exactly which one. The commonest one, do you know?
think that's from where you get an external
Yeah.
feeding vessel. I can't
Yeah.
remember the exact technical
Yeah.
name for
So
that.
that I think that's type 2, and that's what this person had, which is why you can embolize them. Because
Yep.
what you're trying to do is, so what you get is retrograde flow, usually through the spinal arteries, is my recollection. Okay. And so what they do, if there's one particular one, then they can go in and embolize that one, which is what this person had in the past. So let's get down to, okay, again, there's the stent. Now, just as we go through there, so what sort of things are you looking for?
Yeah, so looking for color flow outside of the stent, but within the
Yeah.
aneurysm.
Yep.
Increased size of the aneurysm compared to a
Yep.
previous scan, and
Mhm.
potentially, as we said, from retrograde flow, a vessel that might be feeding into it from somewhere else.
Yeah. So you worried about this bit of color there?
Well, it is
There's a
outside
bit
the
there.
stent,
Yeah.
so potentially that is significant. Yeah.
Yeah. Is there anything else that could give you color there other than
Yeah.
a
So
leak?
I think if you had potentially your gain set too high, you could get
Yeah.
color from the wall of the
Mm.
pulsatility, creating artifact,
Yeah.
causing flow.
Yeah. Yeah. So there's actually a few artifacts. One is you might have flash artifact, just from the movement if things are too high. The other thing is, if you think about the stent surface there, it's a nice bright reflective surface. What do you get behind bright reflective surfaces?
So mirror artifact.
Yeah. So how would you tell whether this is an artifact or is that truly stent leak? Endo leak.
So you could get an alternative view. You could rotate on long and see if it was still there. See if you could define it further. You could adjust your color gain setting and see if that
Yep.
changed the appearance of the color
Yep.
flow.
Yes.
You could put spectral Doppler on as well and have a look at that.
Will
No,
SpectraDoppler tell you?
no, because I suppose it would still give
That
you
could still give you the
flow.
same sort of,
Yeah.
I mean, I guess it'll tell you the difference between flash artifact because that just sort of looks like a big blurry mess on the spectrum. Yeah. Now you said you could change your view by going from transverse to longitudinal. Is there any other way you could change your view?
If you could fan up or down to
Yeah.
change your Doppler angle potentially.
Yeah. I mean, where's your beam coming from here? It's coming from the top
Oh yeah,
and
okay.
it's
So if you
sitting
come
there.
from the side, you'll
Yeah.
avoid that posterior wall. Yeah.
Yeah. So if you come from the side and you imagine then your image is going to be rotated 90 degrees and you still see color here, well, it's not a mirror artifact anymore. Definitely not, because it's got nothing to mirror off. So as you've said, you optimize your settings to make sure that you're trying to eliminate the artifacts that you can that way. Predominantly, that's going to be flash artifact. You can put spectral Doppler on it to say, does this look like a true trace in terms of flow, or does it just look like it's, flash or background noise? And then try and come in from a different angle. And if the color stays in the same place, then it's probably an anatomical feature, not an artifact. Artifacts tend to move as you move the probe, whereas the anatomy doesn't. I mean, the image sort of rotates. It looks like it's something, but if you sort of, in terms of its relations, yeah. So all of those things. So certainly you're looking at that, I'd say, yeah, maybe, but I'm not particularly fussed by that loop there because, I often see things that look like that. Let's see if we can go a little further on through this to some of the other stuff. And the one I want to show you, there we go. So that's to the right-hand side of the graft.
Okay. So that's just a still image rather
Yeah.
than a loop, presumably.
Yep. Yep. Yeah. So again, you have to make sure it's not really an artifact.
So now you've come off to the side,
Yeah.
outside the stent, and you're still seeing color flow.
Yeah, and I think that's a different area of color than what we were seeing before, and it's not a great image because the machine was struggling a little bit. It's quite an old machine, that. But again, to me, that looks like it's probably a real it's a trace of a real vascular flow. It doesn't look just like movement artifact, flash artifact, or something like that. Okay. Yeah, so this was a type 2 leak, and it's actually uncommon on ultrasound to be able to see that with color Doppler, because the sensitivity of color Doppler generally is not high enough for those small, slow leaks. And we see that both when looking for endo leaks, but also other things where you're looking for small amounts. Contrast is much better. There's a lot of argument in the literature as to whether ultrasound contrast is sufficiently good, and that aortic stent observation and follow-up could be done with ultrasound contrast rather than repeated CT, because there is some speculation that one of the reasons that there is no better long-term survival between open repair and endovascular repair is that the endovascular repairs require repeated doses of contrast, and eventually that catches up with people, knocks off their kidneys, and so their long-term mortality, it removes the early mortality benefit that you get from endovascular repair, the operative advantage of it. Okay. All right. I think that's about that's the main. Yeah. That's not so great. But yeah, that we could actually sort of see a little bit of the leak on that one. And sometimes you will get much more dramatic leaks, particularly if you get the leaks where it's where the main ones I've seen it where you pick them up is the leak at either the proximal end, the distal end, or in with the trouser leg, where the trouser leg is joined into the abdominal part. Okay. Does everybody know how they do the endovascular stents for the aortas? Worth just having a look. So they have I haven't got anything I can draw with here. So what they do is it's like a one-legged pair of trousers, and that goes in one side, and then so it sort of comes down, and then it does this, and then they feed up the other part, put it in, and join it in. And that's how they come in through, so that they get flow to both femoral arteries. And so that's one of the places where you can get a leak as well. Okay. But yeah, make sure you have a read of the descriptions. And I think from memory, that's a type 3 leak, but please don't quote me on that. You should look it up. Okay. All right. Let's start talking about veins, I think. Oh, here we go. Sorry, one more arterial one. Let's show you this one to follow on a theme. Okay. Dion?
Yep, can you hear me?
Yep, I can hear you. So this is a chap who said he noticed he had a lump in his groin that got bigger over 3 days, but then it was the weekend, so he decided to just wait at home and see what happened, and it didn't get much bigger over the weekend. But then he came in on Monday. I think he went to his GP, and the GP said, yeah, I think you better go into the hospital. So he came in on the Monday.
So that is the right external, what's it? Common femoral artery.
Yep.
Groin area.
Yep.
So there is a complex echogenic mass in the right
Yep.
groin
Yep.
with a, that looks like mural thrombus.
Yep.
This is a pulsatile structure
Mhm.
in the center. Is this an iliac aneurysm with complications with potential rupture?
Yeah. Yeah. Okay. So if you look at there, okay. So there,
Mm.
what do you think that structure there is? I agree with what you've said.
Um,
The bright white thing there.
Is that
Well, let's see if I can. Let's see. I think we've got some bit of color in there as well.
yeah, or is it in a fistula? I can see now.
Okay. Yeah. Well, first of all, let's go back. So, I mean, first of all, I didn't say, but you know, to me that looks like something somebody's
Thick.
put in there.
Yeah, it looks like a stent, eh? Yeah. How
Yeah,
old was
so,
he? I thought it was a young guy. No, it was an old guy.
well, it doesn't matter who's old or young. Somebody's put a stent in there.
Yeah.
I think he was actually quite old, but you know, I'm not sure it's dependent on that. So he's got a stent.
Yeah.
And around the stent, as you said, he's got a big heterogeneous mass that kind of
Yeah.
looks a bit like blood clot.
Yeah.
And then in the middle of that,
yeah, it looks like a pseudoaneurysm then.
Yeah.
Probably. Yeah.
Yeah. Now
Ideally,
it's a little hard to say whether that's a true aneurysm or a pseudoaneurysm because if
yeah.
I mean, I don't know where the actual wall of the common femoral artery is. You know, this might actually all be an aneurysm, a femoral
Yeah.
artery aneurysm.
Yeah.
The fact that the stent appears to end down here means, yeah, it might be a pseudoaneurysm. I mean, I'm not sure we can actually say, but I think what we can say is that at the distal end of the stent, there's a pulsatile area surrounded with a lot of thrombus, suggestive of a leakage where the stent is meant to join. So let's see what other pictures I've got of this. So again, and here, you know, we were talking about looking for color flow outside the stent.
Yeah.
Well, that's color flow inside the stent, so that's good. Meant to have that. But this bit here, this is definitely outside the stent, and so not where we would expect to see it. And if we look longitudinally,
Yeah, I think that makes it more visible. Yeah. Okay.
yeah, you can actually see the stent and the stent's ending here. And all this stuff is definitely not, you know, a normal thing. You see the stent and the vessel's tightly adherent because this is the distal end of the stent. So that should be adherent to the wall.
Mm-hmm.
And this is showing that there's leakage out of it. So that's, I can't remember. That might be a type 1. Is type 1 the distal? I can't remember. But that's leakage at the distal attachment of the stent, whatever type that is. Okay. And again, we can sort of see it there. Okay. And my recollection is the treatment for that was they put a stent in. They went up, put another stent in that joined onto that stent and went down a bit further and joined on to where the vessel was back down to a normal caliber. And they had a what they look for is a nice straight area of a constant caliber to be able to attach the stent to without excluding any important branches. Okay. So that's another endo leak. And again, one of the ones big enough to see on colour Doppler. And yeah, he probably shouldn't have sat at home on the weekend, but he did. All right. So moving on from our arteries, veins. We certainly do a lot of DVT scanning. That's the main thing. Oh, sorry, getting back to arteries. As I said before, you need to know about low resistance, high resistance, some of the different terminologies with that. What's normal, what's abnormal, what a complete occlusion looks like, those sorts of things as well. But that'll probably be covered in the didactic session on vascular. So yes, as I said, moving on to veins, that is something that we do a lot of. So you're expected to know both a lot about the technique because you're expected to be good at it. You should know the theory, in particular things like, do you scan the whole leg, or do you only look for proximal DVT? What are the advantages and disadvantages of those strategies? Because there are different places around the world that will do different strategies. For people who are not well practiced, proximal DVTs are much, much easier. So some people will say, is it reasonable, or is that just people playing it, doing something inadequate, and if they're not doing it properly, they shouldn't do it at all? So I do think you need to know and be able to discuss that reasonably and give both the pros and cons on both sides of that argument. One thing also is, do make sure that you know the nomenclature of the veins accurately. Okay, don't say superficial femoral vein, right? It doesn't exist, and what's more, people have died because of it. Okay, I certainly have seen one person who died of a PE because their thrombus of their superficial femoral vein that was diagnosed whilst they were on the geriatric ward was thought to be a superficial venous thrombus, and therefore they were not treated. And there was a little run in WA of about 3 cases in 1 year of that happening that the coroner reported on. So it is actually a big deal. It's not just people being pernickety about nomenclature. All right, let's have a look at, let's have a look at this one. Okay. Let's start off. In fact, no, sorry, I've just changed my mind before I show you that one. I'm going to show you this one instead. Actually, I must admit the pictures aren't quite as pretty, but let's have a look. Okay, who are we up to? Whoop, my little list down. Let's swap the order around a little bit. Okay, I've got Claire, Jenny, and Min. Does anyone want to volunteer? I don't think any of those people are sitting the exam, so there's no obligation. But if you feel brave, okay, Claire.
I'll be brave.
Wonderful. Okay.
I might not be good, but I'll be brave.
That's all right. Okay. What does that image show? What are you looking for? Why do we do it?
We're looking to see, so it's the external iliac vein, and we're looking with color flow Doppler,
Yep.
and we can see that the flow is away from the probe.
Yep.
we can do, we're doing a Valsalva maneuver. I think we're potentially doing a
Potentially,
dynamic maneuver.
Yeah, that's actually just off normal breathing,
Okay.
normal breathing. But yep.
So doing dynamic maneuvers can demonstrate complete occlusions, proximally or distally, depending on what the maneuver is that you're doing.
Yep.
So the suggestion that the flow's moving away.
Yep. So the flow's in the normal direction. How much of the lumen is filled with colour?
All of the lumen is filled with colour.
Okay. Is that good or bad?
I think that's good.
Yeah. Right. So that's basically what we're looking for on that. Is there is flow, and it kind of fills the lumen. Okay. But of course, one of the things you'd quite rightly point out is if you crank up the gain enough, you can make any flow, bleed out and fill pretty much anything you want to.
Yep.
So that's one of the limitations of this image, and why color Doppler on its own is not the definitive test for thromboses, because there could well be a partial thrombosis in there, and if I've got the grain cranked up high enough, you just won't see it. So that's good. That's that one. Okay. So let's go back. All right. So this is coming onto our dynamic maneuvers. Okay. And I've got that one there. So ignoring the little arterial trace that I've picked up because of a bit of beam width and beam thickness artifact, what are we looking for there, and why do we do this bit?
So I think what this is demonstrating is when we're looking at the very bright part of the trace, is that we're seeing respiratory variation.
Yeah.
But then I think in the broader section of the flow that's going away from the probe, we've asked the patient to do a Valsalva and hold the breath and augment that.
Yeah, so some people do Valsalva. To be honest, personally, I usually just tell them to take a deep breath, and I find that's enough.
Yep.
If I'm not sure or they don't, then I might get them to Valsalva. But I think, I usually find just normal deep breathing will be enough, and that there's a bit of a loss here, a bit more here, so there's respiratory variation. What does that tell me? Why do I want to know about respiratory variation?
It helps you to demonstrate whether there's contiguity between the external iliac vein and the right atrium. So if there's a big thrombus in the IVC or between the right atrium and the external iliac vein.
Absolutely correct. So, I think of it and go, well, are the thoracic pressure changes being transmitted to the point where I've got my probe and where I'm measuring it? And if they are, that's good. If they're not, makes me think there might be something that's obstructing either the flow, but certainly the pressure transmission. Yep, right. And what's that one looking at? Again, ignore the arterial spikes in the background.
So that's saying augmenting.
Yeah.
So I'm not sure if there's pressure being pushed distally on the limb, and so there's increased venous flow.
Yeah.
I'm a bit confused why it's in the same direction.
Yeah, so what we'd normally see is, you normally see the normal variation with a bit of breathing and stuff. And then that's the actual bit there where we tried to augment. And I agree. It's a bit hard to say that because it's pretty poor augmentation, isn't it? I think so. Normally you get a nice big squirt and it comes down and it wraps around so you see it on the other side. So this is a very blunted augmentation.
Yeah, okay. All
right. So do you have any idea what the different causes of that might be?
So this is again with respiratory variation or respiratory augmentation. So any like thrombus within the lumen or an extrinsic compression from outside the lumen. So that could be a mass pushing on the vessels or an abdominal compartment syndrome or something causing increased pressures.
Yep, that's one group. Yep.
Fetus, would it be in pregnancy?
You certainly can. So any sort of, I mean, the way I think of this is, somebody down there has squeezed the calf. So what we hope to see is there was a calf full of blood in all the veins. Somebody squeezed it, and you have a big squirt of blood going up through the vessels. So first of all, if the calf was too high up, or more commonly, if it's a big leg and it's resting on the bed, so the veins are already compressed, you might not get much augmentation. Because, if you got, and the really tricky ones, you got someone, 130 kilos, your hand can't really go around the leg. The leg's already resting on the bed, so the veins are already pre-compressed. There's not much blood squirt up. So you've got to try and get the leg off the bed, let it fill with blood, and then put your hands right around. And again, it's hard, particularly if you're there on your own. You got one hand and it's a huge leg. Maybe it's just that I didn't squeeze hard enough, or I didn't get a proper grip around the calf, or it's really painful in the calf and you can't squeeze there, so you're trying to squeeze around the ankle. So maybe it's technically not very good. So those are the technical reasons. You've then got, well, if I'm squeezing at the calf and there's a column of blood that's going up, but there's a thrombus between where I'm squeezing and where I'm measuring, I'm not going to see a big squirt. So maybe that's why I've lost augmentation, because that column of blood cannot transit up properly. And that can be because of obstruction between where you're applying the pressure and where you're measuring, or even if you've got a more upstream obstruction, it again may still impede the flow of blood. So it's a really non-specific thing, but it tells me something's wrong somewhere. Okay. So,
great.
Particularly for those sitting the exams, you are meant to be able to describe the findings in both normal and abnormal with these dynamic maneuvers, be it respiratory or Valsalva, and with augmentation, and be able to rattle off a list of causes as to why you will lose those expected responses. All right, so in this case, we've said there's a problem. Okay. So we're looking here. So what are we looking for in this series? And it's always really hard on the stills. So there we can see.
So on these, we're looking for compressibility of the veins. And if we can't compress them, then we assume there's thrombus there or a mass inside the lumen.
Yep. Okay. So we go through, and what I'm going to show you on here. Okay. Often the most sensitive sign is when somebody's written something at the top saying they couldn't compress it, because it's a bit hard to see on here. You hope probably would have got better pictures with the linear probe. I will often use the abdominal probe if there's a big leg, but here we're saying there's non-compression. Okay. Now, one of the things is, then we have a look here. So we can see here is the common femoral dividing into the femoral and the deep femoral vein. Okay. And within the femoral vein,
we can see a hyperechoic mass filling the lumen, and we're assuming that that's thrombus.
Yes. Yeah. So what are the characteristics of thrombus normally?
It's not compressible.
Yes.
Fill the lumen.
Yep.
The echogenicity changes over time.
Yeah.
And I can't remember if it's more hyperechoic acutely or more chronically.
Okay.
More chronically, it might get some reticulations within it. So some little recanalization.
Yep. Okay. All right. Ben, quickly jump in. Which way round is it? What's the difference between old clot appearance and new clot appearance?
I actually don't know either, but I'm going to go hypoechoic or the change as
Sorry, hypo for, okay, so acute clot, hypoechoic or hyperechoic? You got a 50-50.
yeah. I'm going to go acute clot hypoechoic, chronically goes hyperechoic.
Correct. So it starts off dark, and sometimes it can be so dark, particularly depending on your settings, that you can't actually see it. And so the only thing you lose is your compressibility and your color flow. But when you actually look for it, it just looks dark. Most of the time it does look grayish and you can see it. But again, particularly if you've got a really big leg and you're having to look quite deep, and if there's some edema in the leg as well, sometimes it's actually quite hard to see the clot per se. But as time, there's a number of things that can happen. It gets brighter, it can recanalize, so, and you can get, particularly a more central channel. But also, if you think back to the DVTs you've seen, are the veins big or small? The clotted veins.
Acutely big,
Yeah,
chronically small.
yeah, so they shrink. Do you think that one looks big or small? Bright or dark?
Smaller than the profunda.
Yeah, which is a bit odd. Normally the profunda's a bit bigger. Normally the profunda is the smaller one. So we've got a small clot that's bright, which is not surprising because this guy also said he had a DVT a year ago. So then that raises the question, well, how do we interpret this? And again, that becomes quite a difficult question, and is certainly something that you will need to be able to discuss or describe, because it's not an uncommon clinical scenario. Because people who've had DVTs in the past not uncommonly get post-phlebitic syndromes. So they have a tendency for the leg to swell. When their leg swells, some point they turn up in hospital. Somebody says, I've got a patient who's got a history of thromboses, venous thromboses, and they've got a swollen leg. And then you've got to try and work out, is it new? Is it old? Okay. So there are things in the clot appearance. There's also things like, have they got development of collaterals and so on, which would suggest that there's certainly some old component. And of course, then you get the trickiest situation where have they got acute on chronic? So we know they've got a chronic clot, but now have they got acute clot on top of it? All right. So what's the easiest and most definite way to answer any of those questions?
Check the old scan.
Yeah, absolutely. And that actually is one reason why I actually recommend all people with DVT should get a scan at some point at the end of their treatment, because pretty much guaranteed at some point, I guess maybe if they're 99 years old, but at some point they're going to turn back up. Someone's going to be asked to rescan them and have to try and work this out. And it's really quite difficult if you don't have that old scan. So we did have the old scan and it said there was clot in the femoral vein before. Okay. The other thing I want you to notice is that those changes in the dynamic maneuvers, particularly the augmentation, they will persist once you've had old clot, even if it recanalizes, because it tends to be narrower, doesn't allow the blood to flow as well. So you tend to still get persistence of those changes. So I think that was the main thing. And then he also had some calf clot, and I think we decided femoral junction into calf. I think we decided that this was all old. But again, it's also, this patient was already was still on anticoagulation at this point as well. So the ramifications are actually really significant as well, because one of the things is that somebody who gets a clot whilst anticoagulated, that's quite a complex clinical scenario a lot of the time. And it's really important because you can't just go, oh yeah, here you go, have some apixaban and toddle off. Because if they're already on something, you've got to work out A, why is it happening, and B, how you're going to change their anticoagulant regime. So it can be quite a complex question. All right, let me stop on that one. So yeah, that's a little bit about the dynamic maneuvers and so on. That one. So this one I want to show you. This is what I'm going to do before, but I want to show you that one first. Okay. Let's have a look here. All right. So I don't know. Jenny, are you willing to comment on this?
Really new to
Yeah.
the course. Hi, Adrian.
Hello. I know.
Um,
Don't be scared. I promise. Everyone here's nice till you
okay.
get to the exam, maybe. But anyway, that's later. Mhm.
So it's a curvilinear ultrasound still image of the left external iliac vein. There's
Yep.
color Doppler that's been placed on the image.
Mhm.
I'm not seeing any color over that left external iliac vein.
Yep.
I'm therefore suspicious,
Yes.
but I guess as discussed before, I've got to check the gain, make sure
Yep.
that I haven't undergained or
Yep.
overgained.
Yep. Okay.
I probably will have to change the direction of the probe to look at it in two
Yes.
planes as
Yep.
well and check.
Yeah. Yeah. Okay. Usually, I mean, the vessel should be running down here, so it should have a reasonable Doppler angle. You may well be asked about Doppler angles in the exam and optimizing them. That's one of the things. I can see Sulla as he's looking at this image, he's going tut tut. He's a bit critical of it because he knows it's my picture. Because what's this number here show?
Right. Let's see. The gain?
Yeah,
The
well,
scale,
the scale.
the
Yeah.
scale of
So
the
22 for Venus. To be fair, most of the time you quite easily see Venus flow on that. But before I'm going to say there's no flow, I probably need to drop that down, don't I? Because, you know, we're not looking at an artery, we're looking at a vein. So maybe it's just slow flow. Okay. So that's what it looked like in real time.
I am seeing that within the vessels, there seems to be a hyperechoic
Yeah.
area that I'm suspicious that might be a thrombus.
Yeah, I agree. Here it sort of looks quite bright. And the other thing is if you look, you know, you can sort of see a little bit of spontaneous echo contrast. Yeah. Okay. So what do I want to do? So this is the respiratory variation we were looking at and compared to the other one.
I guess compared to the other one, there isn't much respiratory variation.
Yep. And again, the augmentation, very blunted. Yep. So what's interesting is when we did the compression, it all fully compressed. Yeah. Let's see if I should have, we can go down, that's a bit further down. But, yeah, don't want to show you those yet. So what's more accurate, compression or color flow?
Color flow?
Maybe try again.
Compression.
Compression,
Okay.
yeah.
Compression.
Yeah. So what we actually saw here, and I mean, we can actually see it on here, when we compress this area, it's actually fully compressed. So in some ways, like, if you when you're going to put a cannula in, you put a tourniquet on, and I always leave the tourniquets on for a nice long time to get the veins nice and full. And sometimes they do look full of grey stuff, but as soon as you compress them, it sort of moves on because the blood's all sitting there, sort of probably getting a bit sludgy, but certainly you've got all that spontaneous echo contrast. And all of this is just really slow blood flow. So where do you think the problem is?
Potentially higher up
Yeah.
in the vein.
Yeah. Yep.
So, like if we're talking external iliac, I'm thinking the IVC.
Yeah. So the IVC, bit hard to see on there, but it was actually quite small. Thought that looked all right. But that's where we compared the left external iliac vein, which we've seen that image before. And I thought, right, let's just compare it to the right. So here I've changed the scale down to 10. And on the right side, there's lots and lots of colour flow. On the left, virtually none. And hopefully, and when we looked at the common iliac vein, so coming up through the abdomen, couldn't get any colour there. Now, again, you look at this and you go, well, the Doppler angle here is not great. And seeing flow on the common iliacs can be difficult because we're perpendicular to the beam. But when we had a look on the right for comparison with exactly the same settings, because I've dropped the scale down, I've cranked the gain up to try and see any flow. On the right, we very easily see lots of colour flow. And on the left, I couldn't see any at all. But it's difficult to be sure on that. So this lady had an isolated iliac vein thrombus. So the other sorts of things to think of are, as somebody mentioned earlier, has she got a big mass in her abdomen that's compressing? She was about late 50s, early 60s. So the large mass was not going to be a pregnancy. But, one of the things we thought was, oh dear, has she got, an ovarian cancer or something with a pelvic compression? Has she got a retroperitoneal tumor doing that sort of thing? Has she got a renal cell carcinoma that's invading her IVC and is causing thrombus in the IVC? Although that's usually more of a bilateral problem in this case, but it's not always symmetrical. All these sorts of things ran through our head. She then got a CT venogram, which showed an isolated segment of thrombus sitting in her iliac. And the thought was, because there was nothing else, the rest of her abdominopelvic CT was normal, that probably this had been sitting in her leg and then had dislodged and was currently sitting in her iliac veins, the left iliac vein from where it had embolized to. So we thought it had started in the leg, broken off, and was currently just lodged in the iliacs. And she got anticoagulated for that, obviously. Okay. So that is very uncommon. That is one of the reasons why, there are some people who argue about, and again, this is something for the exam, you're expected to be able to discuss. Should you do a 2-point or a 3-point compression test for diagnosing DVT? Is that good enough or is it not good enough? We obviously do a lot more than that. What is the justification for doing that? Because, particularly, a 2-point a 2-point DVT scan, which, to be fair, is not actually done at just 2 points if you read the original paper. Takes, a minute? So why don't we just do that? Surely that's much more efficient. One of the reasons that we say, first of all, I will sometimes do that sort of scan. I usually don't do just a 2-point, but say in the setting of a cardiac arrest or peri-arrest patient where I'm thinking they might have a DVT, because if I diagnose that, it makes the presumptive diagnosis of their arrest or hemodynamic state pretty definite. Somebody comes in collapses, is hypotensive and has a DVT, most likely they've just had a massive PE. But for routine ultrasounds, I think certainly for people scanning at the level we are, then it is reasonable to expect that we will do the more extensive scan, and these are the cases why. These are rare. I've only ever seen, I can certainly remember 2 definite, and I think maybe through, is that a different one? Anyway, they are rare, but if you just do, if I just did compression on this lady, all her leg veins were compressible. Now, hopefully, what I would hope is that even if that were all you're doing, if you saw that, you'd go, well, it might be compressible, but it isn't normal. And even but if you're on the transverse view, you might miss that. So this is the sort of case that is used as justification for doing those dynamic maneuvers. And as I said, you're expected to be able to discuss whether that is reasonable, whether that is unreasonable, what is the likely miss rate if you just do, say, a 3-point scan or a 2-point scan or a proximal scan, or with compared to doing a full comprehensive leg scan. Okay. So any of the examiners got any comments of anything else big that I have missed out at this point? I'm going to stop sharing there. Got a couple of comments in the chat from people. Andy's gone. All right. This is it.
Sorry, I've got to run, Adrian.
Okay.
All right, thanks. I'll see you all next week. Bye.
All right. See you. VJ, what other big areas do they need to know that I haven't mentioned yet?
No, you kind of already touched on one thing. For the candidates to know about how much they need to know below knee DVT scans. You want to quickly go through them on what is the expectation for the examination is?
Yeah, I mean, I might leave that because that may well be covered. I don't know who's giving the vascular talk. Is that you? I don't know. I haven't actually looked on the program to see. So I might leave that because I suspect that may well come up. Don't forget upper limb DVTs as well, everybody. I haven't shown you any. Technically, they're more difficult to both perform and to interpret because you can't always compress the subclavian vein, but you need to know about them. The other thing I'd say is you also need to know which of the thromboembolic conditions are treated, have different treatment implications. And I know that's getting into a more clinical sort of question as well. But, you need to know which ones you don't just give them a script for a Pixaban and tell them to follow up with a GP and get a repeat ultrasound in 6 months' time. Okay. So you need to know about Paget-Schrotter syndrome. Yep. You need to know about, goodness, I always forget the names. So Paget-Schrotter is the upper limb DVT. The lower limb DVT. May-Turner syndrome. Thank you, Kylie. I had nominal aphasia there for a moment. So, yep, May-Turner. Okay. And once they've broken off, know about clot and transit as well. Okay.
And the last topic is arterial occlusions.
Yes. Yep. Know about what, an arterial occlusion looks like, stump flow and so on. A little bit about fistula and fistula flows. We don't tend to do the evaluation of fistulas because that needs measurements because I'll often dilate them. But, you should be able to, it's not that hard. If somebody says, is this fistula thrombosed or not? You should be able to look at it, scan it and see. Clinically, it's usually evident, but sometimes not so sure because don't forget, they still pulsate. But you're meant to feel for the thrill. But, if there's any doubt, just put a probe on and have a look. Okay. All right. I've run only a little bit over time, so I think I've talked enough. Anybody got questions? Yeah, Dion.
Yeah, I've just had a patient. It's a really large iliofemoral DVT. A trajectory over 10 centimeters. It's probably going on for 3 weeks. Told my vascular team they don't want to do the CT venogram because I had a good look at the IVC. That looks fine. The right side of the heart looks fine.
Yeah.
But just in terms of severity of iliofemoral proximal DVTs and timing of intervention, what's your experience in that? Because sometimes.
So, I mean, often people do get, we get scared by things that are bigger than normal. Kind of understand that, even though if you look at the evidence, it's not necessarily that strong. So, certainly most patients I see, if the DVT goes up into the common iliacs and certainly into the IVC, they wind up getting admitted. I mean, you do need to know about phlegmosia cerulodolens, but again, yeah, that's actually more of a
clinical.
You diagnose that on what the leg looks like, not what the ultrasound looks like. Having said which, those patients have complete occlusion, extensive occlusion, almost in, I don't think you can get it if you haven't got complete occlusion. So that's certainly one of the indications where you'd consider thrombolysis. They will sometimes do a thrombectomy. They tend not to be very successful for a couple of reasons, because they often rethrombose in the few cases that I've been involved in. And often it's because these patients often have active malignancy, and so they're really in a really procoagulant state. So they go in, they pull the thrombus out, and then it just reclots. And then, usually if it hasn't already been diagnosed, somebody then rapidly diagnoses their disseminated lung carcinoma and they die pretty shortly afterwards. There's been most of the ones that I've seen, I must admit. The iliofemoral ones, Kylie mentioned May-Turner syndrome. And there is some debate as to how both that and Paget-Schroeder disease should be treated. The evidence on both is, as far as I can tell, really poor. That intervention has a definite benefit. Nonetheless, all of those we will discuss with our vascular team. Almost invariably, the vascular team will intervene on them. The timing of the intervention seems to be a bit variable. The Paget-Schroeder, so the upper limb one, does everybody know what Paget-Schroeder syndrome is? This is upper limb DVT, usually in young people, associated with exertion, and it's thought due to compression of the subclavian vein, either due to a cervical rib, a cervical band, or to a narrowing between the clavicle and the first rib. And so on one end of treatment, people say it's just that upper limb DVTs have a lower risk of PEs. They're they have lower complications than lower leg DVTs. Give them a Pixaban, that's it. Don't do anything more. The vascular surgeons will often go, yeah, there's not much evidence, but we're going to admit them to ICU. We're going to thrombolyze them. If they thrombose, we'll re-thrombolyze them. I've seen somebody get thrombolyzed 3 times in 2 days for a Paget-Schroeder syndrome. And then we will go and do a first rib excision plus or minus stenting of the vein. So you sort of have this huge spectrum of just how aggressively you should treat these. And as I said, the evidence really isn't there. May-Turner syndrome. Does anybody know what May-Turner syndrome is, other than Kylie? Because she knows lots of stuff.
I can't remember what it is, but something causes compression of one of the iliacs and
Yeah.
increases your
lumbar spine, isn't it?
No, it's not the lumbar spine, it's the artery. So it depends, you normally have your aorta and your IVC, and they come down next to each other, and then they split, and they got to cross. And it's really whether I find it really hard to sort of tell on the imaging. They go, yeah, well, it either crosses there or it crosses there, and that's May-Turner, and that's normal. You look and go, really? Okay. So it's if the iliac vein is compressed by the crossing iliac artery. Okay. So it's the left iliac vein that gets compressed by the right iliac artery. I think I've got my left and right around the right way there. And classically it occurs in young teenage age females. I don't think I've ever seen it in males, but we see one every two, maybe 3 years. So it's not common, but it's not that uncommon. And they tend to have extensive DVTs, and it goes up to the iliac to the point of compression. And again, the vascular surgeons will talk a lot. They will talk about thrombolysis and they'll talk about stenting. Most of the ones I've seen, they have treated with anticoagulants. They have not thrombolyzed them, but they have stented them. And again, when on my brief looking to try and see how good is the evidence that is the best treatment, there seems to be lots of opinion and very little actual hard data. It doesn't mean it's wrong, but I don't think there's much data there. VJ and Kylie, do your vascular people do that?
We don't have vascular people, I'm afraid. I don't know.
I don't have much knowledge on that, what the surgical treatments are.
Yeah. So it's not necessarily something they have, if with the stenting, they may not do that acutely. Some of them seem to go, no, we anticoagulate and then we will get them back. And then we will stent them in a few weeks' time or a couple of weeks' time. This sort of thing. So it seems to be variable, but certainly I think it's something you need to know what it is. You need to be able to recognize it if you see it. And I do think it is reasonable to say this should be discussed with a vascular surgeon, because to my mind, it's still a little bit of a grey area as for treatment. But certainly across WA, the vascular teams do seem to intervene on them. So I think it's fair enough to at least put it to them, and then they can decide as to what they want to do in concert with the patient's wishes, of course. So yeah, Dion, your one, was it an old person or a young person?
No, it's a patient with Crohn's disease with an active flare, and she had previously a portal vein thrombosis as well.
Right.
And so she is, prothrombolic, but she has extensive clot burden. So she will get tomorrow morning a CTV, I think.
Yeah.
They didn't want to do it now. Yeah.
Yeah, but again, I mean, you could argue, what's the CTV going to show? She's got extensive clot burden.
We know that. That's right.
I think that the more difficult question is, what do you do about her extensive clot burden? Do you just put her on an oral direct DOAC? Do you put her on a heparin infusion? Do you put her on Clexane? Or do you thrombolyze? Certainly, for us, they tend to get admitted, and as soon as they get admitted, they go, put them on a heparin infusion. And I've always thought, I mean, almost every study comparing heparin infusions to low molecular weight heparins have shown that low molecular weight heparins gives you better, more stable anticoagulation. And yet, as soon as it's something where you think, yeah, I really do want good level of anticoagulation, they put them on an infusion that we know often becomes subtherapeutic at times and often overshoots and all this sort of stuff. But anyway, I don't understand why, but everybody loves heparin infusions as soon as they're admitted where I work. So as I said, in that case, to me, the interesting thing is how do you treat that person knowing that they're still going to have that prothrombotic state for a while? What's the best anticoagulant? And I certainly don't have the answer. That's where you ask the clever hematologists. Okay. Thanks, Ella. We'll see you later. So, all right. Any other final burning questions? All right. Okay. Well, thank you, everybody. Well done for all the answers that we had. And I think I can't remember there's a session on next week, but I can't remember what it is. It's in the chat. If anybody's got any other burning questions, just let me know. Okay. We'll see you, everybody. I'll stop the recording.